The information and photographs contained in this presentation are the property of Candela and its consulting healthcare providers and are provided for educational and discussion purposes only. By sharing this information, neither Candela nor any of its consulting physicians give you the right to use the information presented. By participating in this webinar, you agree not to photograph, reproduce, or distribute any of the information or photographs presented during the webinar. With that, I would like to introduce Professor Firas Al-Niaimi, an award-winning dermatologist with nearly 20 years of experience, who will be moderating tonight's event. Professor Firas, the floor is yours.
Thank you very much, Aviva. Good evening, dear colleagues, and welcome to our webinar on pigmentation. We have a stellar lineup of speakers who I all know personally at a personal and professional level, and they have huge experience. So this is going to be a fantastic webinar. We are going to take questions and answers.
Sorry, I'm here.
We are going to take questions and answers at the end. So please submit your questions at the end. So the speakers who I'm going to introduce, we are going to start first with, after my talk, with Dr. Didac Barco, who is a dermatologist with a lot of experience, based in Barcelona, Spain. Then we'll move over to Professor Giuseppe Scarcella, who's based in Verona with over 30 years of experience with laser dermatology, some fantastic cases. Then we'll move over to Dr. Cordula Angel Frank, who is based in Majorca, in the Canary Islands, with a lot of experience with patients with a lot of sun exposure. Then we'll move over to a dear colleague of mine, Professor Alina Arabiskaya, from the beautiful city of St. Petersburg in Russia, but again, with a lot of experience with lasers and a lot of scientific publications on lasers. And then we'll finish off with Dr. Renita Rajan, who runs a very successful clinic in India, where she has huge experience with pigmentation, and particularly complex pigmentation and pigmentation with skin of color. Right, so why talk about pigmentation? Well, I think it's obvious that wherever you are, and certainly here in our Western Europe part, that we are seeing many patients with skin of color. And it's projected that in the United States, by the year 2060, that there is going to be more people with skin of color than the lighter skin types. And with skin of color comes the problem of pigmentation and pigmentary disorders. So what we are seeing, that I certainly work in London, and I see probably about a half of my patients who are classified as higher skin types, and with that comes a lot of pigmentation. So wherever you are, it is projected to be a growing issue of concern, and fortunately we do have some energy-based devices and some treatments to treat these cases of pigmentation, hence why we are having this webinar tonight. So we're just going to run over some of the devices from Candela that are involved with the treatment of pigmentation. And the first one I would like to introduce is the PicoWay. So the PicoWay is the picosecond laser from Candela. And what you see here in the image, you see all the different handpieces that are available. So we have many different wavelengths. The first one on the top, which is the zoom handpiece, has two wavelengths, which is the 532 and the 1064. So we can treat superficial as well as deep pigments. We can treat the lighter skin types as well as the higher skin types. And then beneath that handpiece, you'll see two different handpieces of the 785 handpiece and the 730 handpiece. And these are two unique wavelengths that are mid-wavelengths between the 532 and the 1064. So they are particularly good for some of the epidermal pigments in the higher skin types, or some of the more superficial dermal pigments, again, in the higher skin types. And sometimes we combine, and this is the beauty of having multiple handpieces with this device. What we then have on the bottom three handpieces, these are unique resolve handpieces. So they rely on a fractional method of technology of the beams. So we have a Resolve 532 handpiece and the Resolve 1064, as well as a Resolve 532 Fusion. So these handpieces can be used for superficial pigments, as well as rejuvenation and the treatment of scars, including acne scars. Now, what is important to mention is that the picoway has the shortest pulse duration of all picosecond lasers in the world. So we have the shortest pulse duration, which means we rely less on heat, less on photothermal effect, and more on a photomechanical effect. Now, the next device I would like to briefly introduce in terms of what we can use for pigmentation is the GentleMax Pro Plus. As you can see here with the GentleMax Pro Plus, this is the newest version of the GentleMax Pro series, and it has the largest spot size for hair removal, which is a 26 millimeter spot with a faster repetition rate of 3 Hertz and a very short pulse duration, particularly useful for the very fine hairs, which is 2 milliseconds. But what is unique about this handpiece is you can see, because we have the 2 wavelengths, which is the 755 alexandrite and the 1064 Nd:YAG, there are a number of things that we can treat. Now, certainly in the interest of benign pigmentation, we can see that the 755 particularly is a very good wavelength for superficial pigments in the lighter skin types. And this is what we are going to hear about from Professor Araviskaya later. And sometimes we might combine 2 modalities. So we might start with the 755 GentleMax Pro handpiece, and then we may finish off with the picoway, for example, or the other way around. So having multiple devices also allows us to sometimes combine these treatments. So this is the interface, which you can see, and it's really user-friendly, where it says in the middle, so that's Alex. So here you can see that if you choose the alexandrite, which is the 755 nanometer, you can see almost like a speedometer. You can see the range of the fluence. On the bottom left side, you can see the pulse duration range, and you have a huge range from a short to a long pulse duration. In this particular case, with a large spot size of 26 millimeters, so that is the spot size for hair removal, you can go as short as 2 milliseconds. So that is particularly useful for the fine hairs. And then what you have next to it is the frequency, and you can see that you can go up to 2.5 Hertz here. So fast movements. And then we also have the cryogen on the right-hand side, so where you see the numbers 50 over 30, so that is 50 milliseconds of spraying time, followed by 30 milliseconds of delay. This is particularly useful if we're doing hair removal, but as you will see later, for a lot of the superficial benign pigmented lesions that we treat, we do not rely on the cooling. So these are some of the benign pigmented lesions that we can use. The alexandrite for, so freckles, solar lentigos, café macule, and even seborrheic keratosis. All of these can be treated with the 755 nanometer handpiece of the GentleMax Pro Plus. Now, the last device I'd like to briefly introduce is one of my favorite, the Nautilus platform. So the Nautilus is a platform because it has multiple handpieces. And what you can see, it has several IPL handpieces, an Nd:YAG handpiece, and 2 non-ablative fractional laser handpieces. Now, for the interest of pigmentation, if you look at the VL and the PR, so these are 2 handpieces that have a range of wavelengths, which we can use for superficial benign pigmented lesions. The PR530 is the one that we tend to use in the lighter skin types. And for the higher skin types, we shift to the VL handpiece. Now, this IPL is very unique in that it relies on the so-called selective waveband technology, where it cuts off the longer wavelengths that are absorbed by water. So you can see, for example, if we look at the PR handpiece, we have a range between 530 to 750 nanometers. So that is ideal for hemoglobin and melanin. Likewise with the VL, but it's extended to the 950, so it gives us a little bit more of that depth. Remember that water starts to be absorbed from around 1000 nanometer and above. So the advantage of the Nautilus IPL handpieces is that we don't have water absorption, which the skin is composed of, 60% of the skin is composed of water. So therefore we don't overheat the skin, and we can be much more efficient in terms of having the energy for the hemoglobin and the melanin. And you will hear about different parameters, different treatment approaches over all these devices from our speakers. Now, the other advantage of this IPL handpiece is also there is an IPL handpiece for hair removal. And we can customize the spot size because we can use the large spots for larger coverage areas, but the IPL handpiece can also come with a small spot for small discrete lesions. Think of a small lentigo, for example, that you want to treat. So what I mentioned about the selective waveband technology, the advantage of that is less bulk heating. So what you see on the left-hand side is all the other IPL systems that do not filter the longer wavelengths, so they will extend to 13 or 1400 nanometer. So beyond 1000 nanometer, there's going to be excessive water absorption, which will lead to heating of the tissue. And as a result of that, you get bulk heating, which can increase the risk of complications. Whereas on the other hand, you can see with the Norlys, because of the selective waveband technology, we do not have this issue. This is very important, and this is why the Norlys is a much safer IPL, but is also a much more effective IPL compared to the other IPL systems in the market. And one of the other advantages is the ability to customize the pulse duration. Now, we all know from the selective photothermolysis theory that the smaller the target, the shorter the pulse duration, the larger the target, the longer the pulse duration. But what is particularly unique about the Norlys IPL compared to all the other IPL systems in the world is that it has the ability to have a very short pulse duration. And that is as short as 0.5 milliseconds. So yes, below 1 millisecond, which is very unique for an IPL system. So if you think, for example, about diffuse redness in a light skin type patient, where the target chromophore is very fine vessels, we need a very short pulse duration for that. Only the Norlys IPL can achieve that. So the ability of having a very short pulse duration, coupled together with the fact that there is no water absorption, therefore much more efficient hemoglobin absorption, we get much better results in treatment compared to all the other IPL systems in the market. And I have used many of those IPL systems myself. So that is my part. And I hope you will all enjoy this webinar, and we will get your questions toward the end. I would encourage the attendees to submit their questions. And it is my great honor now to introduce the first speaker, who's a friend of mine, highly skilled and talented dermatologist, Dr. Didac Barco from Barcelona, with huge experience in laser dermatology. Didac, the floor is yours.
So first, thank you so much for the introduction, and we are speaking to zoom in into treatment and in combination with therapies to do so. And the first approach, or the first message to account, is that the best treatment for post-inflammatory hyperpigmentation is try to avoid it to exist, right? So not to have these ones. So the first step, what we can do, which are essential, is using protection
I think there might be an issue with the connection here. Dr. Barco, are you still there? Okay, so we'll ask Dr. Barker to reconnect. But what Dr. Barker was emphasizing on is the importance of managing and preventing post-inflammatory hyperpigmentation. And that is not just by protection against short wavelengths, the UVB, but it's also extending that to the longer wavelengths, the UVA, which are not filtered through window glass, and certainly also the importance of blocking visible light, which is blocked through iron oxide. And this is why we now have the new modern sunscreens that will contain iron oxide and also UVA protection. Just checking.
Can you hear me now?
Yes, Dedak, continue, please.
Yeah, great. Thank you so much. And these things should be clearly stated on the consent form, just to reduce any problem if we have hyperpigmentation after any treatment. So there are a few clues, a few clinical clues that may enable us to predict the risk of post-inflammatory hyperpigmentation. And one of the most interesting and simple ones to see in your everyday practice is seeing the palmar creases of the patient, because we sometimes get some surprises in people that are quite fair skin, but they do have a dark creases on the palms, and it is an indicator of risk of having hyperpigmentation after some laser treatments. So this is one of the data that we can collect during the examination and the medical record of the patient. If we notice a risk of hyperpigmentation, we may use bleaching agents before and after the procedure. And once we detect too much inflammation in the original dermatosis, or even after the procedure, we may treat this inflammation as soon as possible to reduce the risk of hyperpigmentation. So here's a clinical example of a girl with PCOS and severe acne, and phototype 4, who was treated with metformin and also 3 sessions of Nordlis VL and non-ablative fractional laser 1550, so to reduce the inflammation and also the risk of atrophy. So the idea behind this treatment was to do a prevention of hyperpigmentation and not waiting until it was already settled. So here's the other side of the face. May we use some bleaching agents? That would be my go-to formula. It can be prepared in any pharmacy. Non-steroid anti-inflammatory, which is in the medicine. It also contains or bleaching agents such as the kojic acid and the tranexamic acid. And last but not least, hydroquinone, right? We can combine all these agents together to make a more efficient bleaching agent. We can also add other natural compounds, but this would be my recommendation as a bleaching agent before any laser treatment when you consider it's necessary. Also, to treat post-inflammatory hyperpigmentation, there is quite robust evidence that oral tranexamic acid is very efficient and safe. You can give it 250 milligrams every 12 hours, or just 1 pill of 500 milligrams per day. And when exploring pigmentation of a lesion, especially on post-inflammatory hyperpigmentation, we should try to deduce or see the signs through the dermoscope if it is a dermal pigment or if it is an epidermal pigment, because the treatment each case, right? The dermal pigment may respond better to the PicoWay and or the 1515 non-ablative fractional laser. And if the pigment is epidermal or both, we may use the IPL and or the non-ablative 1940. That, as you know, it is more superficial. right? So for dermal pigment, Pico or 1550. If epidermal, go with the Norlis or 1940. We should be easy on settings because one of the reasons that post-inflammatory hyperpigmentation appears is inflammation, as the name shows. So we should be careful with the settings and try not to use very short pulses and combine with high fluencies. So the settings I would suggest to treat post-inflammatory hyperpigmentation with these devices would be using the safer handpiece of the Norlis, which is the VL555, with these settings appearing on the screen. If you use the Pico way, that will be the settings that Firas shared with me a few days ago. And if you should use the non-ablative fractional laser 1550 or 1940, that would be the settings I would use. As you can see, they are quite gentle settings. After the non-ablative fractional laser, we have an additional tool in our armamentarium that should be topical tranexamic acid solution, whatever the concentration is. In Spain, we have these two concentrations, and they both work great. So this is an option to apply after the treatment with non-ablative fractional lasers, or even with a Pico laser, with a fractional Pico laser. We can also support the treatment with at-home treatments, applying the bleaching formula we have talked about, also tretinoin at high concentration, retinol also at high concentration, or even ISO below 20 milligrams per day. And what about the risk of pigmentation or the risk of burn when the patient is having oral treatment for acne and they undergo a treatment with an energy-based device? The medicines that are normally given for acne do give photosensitivity for radiations below 400 nanometers. And all the devices that we are going to use for these patients are over 400 nanometers. So there is no additional risk of having problems, and it is not a contraindication to use EBD in consuming patients. There are actually a few reviews about this topic, and this last one clearly states that risk of associated hyperpigmentation or secondary effects if you are under isotretinoin are not higher if you have lasers under this treatment. So that would be my take on treating hyperpigmentation with energy-based devices. And I just want to thank you for your attendance and introduce the next speaker.
Thank you. Thank you very much, Dr. Barco. That was really important. And I think it's a very important topic that you emphasize on prevention of pigmentation with the formula. That's a very useful formula. Just one question, how long before the treatment do you tend to start? Maybe you can explain that, just because I'm sure that there are many attendees who probably will wonder about the time period. When will you start? How long will you start preparing skin before you would treat for pigmentation?
Yeah, thank you for the question. I start the treatment about 3 or 4 weeks before the laser, and I do not stop it before the procedure because it does not have any retinoid or any substance that may cause irritation, because, you know, indomethacin blocks the irritation of hydroquinone, so it is not necessary to stop the treatment before the procedure.
Yeah, thank you for that. I fully agree. And I think this is where sometimes the confusion arises. And some colleagues will say, how long do you stop beforehand? We typically stop when it's retinoic acid, i.e. tretinoin, which is the brand name, because of the local irritation. But if that's not the case, then you don't need to stop. I do the same. I continue to use it, and I start And I also want to reiterate your important point about antibiotics and photosensitivity, because it is photosensitivity to the ultraviolet range, just like you explained, below 400 nanometer. But when we are treating with IPL or with lasers, we are very much in the visible light or in the infrared light range. So therefore, there's no concern of photosensitivity. I think that's very important to highlight. So thank you a lot, Dr. Barco. Stay around for our Q&A session toward the end. And it's now my great honor to present the next speaker, Professor Giuseppe Scarcella from Verona in Italy, with over 30 years of experience with laser dermatology and some fantastic cases. So Professor Giuseppe, the floor is yours.
Thank you, Professor Firas. So, and good evening to everybody. Pico wave, 5 main features. So we can work with the 4 wavelengths with the shortest picosecond pulse, the highest peak power. We can treat a range of that too, but the topic of my presentation this evening is to treat the dermal and epidermal pigmental lesion with the Pico wave. You can see here many different kind of pigmented skin lesion, and when we approach with the laser to treat this lesion, so it's very important to do the right diagnosis before treat this lesion, pigmental lesion with the laser. We have to do the right diagnosis, and the dermoscopy could help to make the diagnosis before treating this lesion here. So just look as an example of solar lentigo, the seborrheic keratosis, pigment AK, the different pattern of dermoscopic pattern. We have 4 wavelengths, so we are able to treat many pigmental lesion in different kind of phototype, Fitzpatrick phototypes with the Pico wave. This is solar lentigo, and so we can work with very low fluence because we have picoseconds pulse, and so also the recovery time, it's very quick. You can see here after only 5 days, and immediately after, the day after, and 3 days after. In this case, instead we use the nanosecond laser, and after 7 days, we can see still some crust. So the patient is not completely recovered after 7 days. Because usually when we use the nanoseconds, we must use a fluence that is at least the double than the picoseconds. Another solar lentigo here with the dermoscopic image before and after. And you see here immediately after the recovery and 3 weeks after the treatment. Several solar lentigo. These are just only after 1 session, and immediately after the treatment, and 2 days after. And also here several solar lentigos with only 1 session, and immediately after treatment. So solar lentigo of the hands with 1 session, and also this case here and the day after. It's important to make the diagnosis, especially when we have the solitary lesions. Solitary lesion must be very careful to do the right diagnosis. This is a big solar lentigo. You see after 4 weeks after treatment, and here is immediately after treatment, and the dermoscopic image. So we used 0.8 joule. If we use when we use the nanoseconds, we work for the lesion like this when 1.4, so quite the double fluence. And this is a Mediterranean phototype, and I suggest to the use of the 20-30% fluence. In fact, we worked with the 0.6 joule in this Mediterranean phototype. And also in this case here, Mediterranean phototype to treat solar lentigo. This patient was treated, had 3 treatments with alexandrite Q-switcher in another clinic with no results. So we made 2 monthly sessions with the PICO at 0.8, and you see the result immediately after the treatment. In this case, we had patients with seborrheic keratosis in the center of a solar lentigo. It's not unusual that a solar lentigo can become a seborrheic keratosis. So we used 0.8 for the solar lentigo, a 2.8 for the seborrheic keratosis on using the 532 zoom and piece of PICO. And this is the results. And this was a benign mucosal melanosis of the lips. So we made a test and 2 complete treatment. You see here the result of the test, the clinical result of the test, and also the dermoscopic result of the test. The pattern, the dermoscopic pattern was a typical, because in this case we have a regular parallel line. So we can be sure that it's a benign melanosis of the lips. You see immediately after the treatment and 2 days after the treatment. In this case, I suggest to do prophylaxis with antiviral just to prevent recurrence of herpes simplex, herpes labialis. For other pigmentation, many literature on treating, on using Q-switcher laser and the nano and picosecond laser. Me too, I published in this case. And you see here, a light pigmentation worsened after botulism treatment. We use the zoom and piece here, the 1064 with the brushing technique. And you see the result after 5 monthly session and no recurrence after 8 months. Also in this case, we have a mixed pigmentation, and we use the zoom and piece 1064 with the brushing technique, and the result after 4 treatments. In this case, this is a café au lait macule. So we made a double test, and to use in the left side the nanosecond laser, in the right side the picosecond laser. You see the 2 days after, and the part that we treated with the nanosecond was not completely cleared after the test. So the 2 complete sessions we made with the PICO, and we needed to retouch the area that was tested with the nanosecond laser. So the PICO we had a better performance with the PICO. And this strange lesion here, with this big lesion of the right, the left cheek of this lady, was a strange lesion. Also the dermoscopy, there is much regression, a gray ring. So we were worried about maybe it was a lentigo maligna. It was a very big lesion, so we made a 3-punch biopsy, and the histological report was pigmented actinic keratosis with atypia, without atypia, a solar lentigo. So we decided to treat with the PICO, but we used the 785 just to go deep, a higher fluence, 785 just to go deeper, and the 532 to stay superficial. And you see here 1 day, 2 days, 7 days, 9 days after the treatment at the final results. This patient was not one of my patients, was treated with a 730 for solar lentigo. And let's go to the resolve and the pigmented, the resolve and pigmented skin lesion. So the handpiece resolve and piece resolve fusion is a fractional technology, picosecond fractional technology, and then it's a photoacoustic effect, and we can use the 552 for the shoulder lesion and the 1064 for the deeper lesion, and we with this fractional technology we are able to have the LIOPS, the laser-induced optical breakdown. Some literature about this, and this LIOPS here. And then after a few weeks, they become fully of neocollagen. And the very interesting was the study of the Spanish colleague, Adriana Ribe, was a clinical and histological study. And just to study the performance, the of this approach, and just to demonstrate the formation of lyobes in the epidermis with the intact stratum corneum, and the laser-induced cavity, the leak in the dermis. And both with fraction and piece, the 532 and 1064, we are able to produce lyobes, but the location of the lyobes, superficial or deeper, they are more related to the energy and not to the wavelengths, not only to the wavelengths. Higher energy induce more superficial lyobes. So the epidermis lyobes, we can have the epidermis lyobes, then the superficial lyobes with the 532 and 1064 if we work with energy that are more than 0.5 millijoule with 532 and more than 2 millijoule for the TEC64. We have the lyobes in the dermis, usually at 500, 600 micrometers, with the 532 and the TEC64 with the lower energy level. So using energy up to 0.5 millijoule for 532 and up to 2 millijoule for 1064. And other study confirmed this approach. So to have the lyobes, why to have the lyobes? So we can, if we have the lyobes in the epidermis, just to treat epidermal mixed pigmentation, uneven pigmentation, photoaging to improve the texture, and in the dermis for dermal pigmentation, for photoaging, or for acne and traumatic scar, and to improve the texture too. About the side effect, we have very low side effect, a very low downtime and discomfort, just an erythema, a light erythema that disappeared in 1 or 2 days, and some mild pruritus and some mild purpura, but very, very down side effect and very down, very low downtime, absolutely. Okay. And you see here, also we can use the Resol 532 and Resol Fusion. So the difference is with the Fusion, we can have a 50% coverage instead of the 10% of the Resol, the classic Resol. We have a ring of low fluence, and we have a higher fluence in the center of the spot. Okay. This was a patient treated after 3 treatment with a pick-away result. Let's go some of my clinical results. This patient with aging and soral impetigo was, this is the result after only 1 session. And here you can see immediately after treatment on the left and 1 day after, as if we compare with the before the treatment, there is not so much difference, because with the result, when we treat soral impetigo, we don't have crust. And so the patients, the day after, 2 days after, is quite similar to before the treatment. So no, absolutely no, or very, very low downtime, very low discomfort. And this is a dermoscopic image of soral impetigo 2 days after the treatment with the Resol 532. After 1 month, 1 month after 3 treatment, and 1 year after 3 treatment, monthly treatment, so 1 year after the result still remain. Dermal pigmentation here, so we use 1.30 because it was dermal, so to go deeper, and the same patients the other side. In this case also was dermal pigmentation, so we worked with lower fluence, 1.30 millijoule. And immediately after this redness that disappeared the day, in 1 day, this erythema disappeared. This was a mixed pigmentation, so we used 2 fluence, 1.30 to go deeper, and 2.10 to stay superficial. And this was mixed pigmentation worsened after Pigmentation treatment. Also in this case, we use two fluents to stay superficial and to go deeper. Superficial pigmentation treated with 2.10. And this was dermal pigmentation with vascular pattern. So in this case, we made a treatment with a pico dye. We alternate pico and dye. 2 treatment of pico and 2 treatment of dye with the parameter that you can see on the slides. And this is the red mask. So we had an improvement of the red mask because was important, the vascular component in this pigmentation here. You see immediately after the dye laser and 4 days after the dye laser, some little crust. This was a pigmentation, mixed pigmentation of the chest after 3 treatment, immediately after the treatment, using the two setting of fluids. So in conclusion, so we use lower fluids, so less pain, less discomfort, and quicker healing time, higher percentage of clearing with best performance. We can work also in dark phototype. We will see after the other presenter. And if we use the result and this, we have definitely no downtime or very, very, very low downtime. And for the dark phototype, for the Mediterranean phototype, so I suggest always to reduce the 20-30% the fluids compared to the Caucasian phototype. And I suggest to do a laser test session before enrolling the patient for a full treatment. Thank you.
Thank you very much, Professor Giuseppe. That was incredible. Very nice cases. And I like how you combine handpieces, but also more importantly, the importance of dermoscopy. I actually had a patient referred to me not too long ago for laser, and with dermoscopy, I could see that it was a lentigo maligna. So dermoscopy is very, very useful in such cases. So thank you for that. I think we'll just ask a couple of quick questions before we move on, just for clarity, because you mentioned with these cases, you do the brush technique. So yes, maybe you could just explain what you mean with the brush technique.
So the brushing technique is a technique that you go several times in all the direction, so vertical, horizontal direction. So, and you pass many times. So you stay with the end piece some millimeter up the skin, and you do like a brushing. Okay.
Yeah.
So it's a painting technique. It's like a painting technique.
It's a multi-pass technique.
So several passes in the all direction. At the end point is the erythema. So when you reach an intense erythema, you can stop.
Yeah. No
purpura. If you see some little purpura, it's better to reduce just a little the fluence. Erythema, no purpura.
Absolutely
intense
correct. Yeah, well, thank you for that. That's very helpful. So thank you very much, Professor Giuseppe. Please stay for the Q&A session at the end. And now it's a great honor to introduce the next speaker, who is Dr. Cordula Anhalt-Frank from Majorca, from sunny Canary Islands. I hope it's somewhat nicer weather there than here. Again, with huge experience using the lasers and the IPL on pigmentation. So Cordula, the floor is yours.
Thank you so much, Firas. Yes, we had 27 degrees today. So yeah, working on a sunny island like Mallorca means, we have to deal with the sun. We have to deal with tanned patients. Our patients are mostly fair skin type, so between type 1 and type 3. So this is what I have most experience with, not so much with darker skin types. And a really great device to use in those skin types is Nautilus. So it's a very versatile EPD and laser platform, which has a guided mode. So it's very easy to use, even for beginners. You have a range of preset treatment parameters, which are tailored to skin types and tanning levels. So, and then the system actually recommends you some parameters that are always good to start with. Additionally to that, we have an expert mode, which allows us to customize the settings, such as pulse durations, effluence, or also pulse type. It's a real ideal platform, not only for beginners, but also for experts, and it gives us a wide range of indications that we can treat with that, and which has a really small learning curve related. So you can expand the system by modules. Yeah, so you can start with IPL only, and then you can add the NDYAC, for instance, or you can add other handpieces of the IPL, or even the FRAX. The non-ablative fractional laser handpieces. We have a very selective targeting in the specific chromophores. As we all know, the most important chromophores in pigmentation, of course, is melanin, but sometimes also hemoglobin. So if we look at, or if you compare the SVT with the standard IPLs, Professor Fira has already mentioned it, we have a very narrow spectrum, so a narrow band focused spectrum here because of those dual Volta filters. So which means we cut off the the longer wavelengths and also the shorter wavelengths, which allows us to have a more specific absorption in melanin and in hemoglobin, and not so much absorption by water. Which allows us also to reduce the energy, to have less cooling, and of course less side effects. So we create less heat in the skin, less pain, and also of course a lower risk of burns and of hyperpigmentation. So that's a very important thing while we are working with Nordlers. If we look at the absorption of melanin, we have 3 different Nordlers IPL handpieces. So the first one is PL400, which is mainly used for very fair skin types. You need to be careful with that and never use it in deep, in darker skin types. And then, as we already mentioned, we have PR530, which has a good absorption in melanin, and the VL555, which has less absorption in melanin and is more suitable for lighter skin types. So on this graph, you can see that again. So PL400 should only be used on really fair skin types, so only on really very light lentiginous, for instance. Otherwise, you wouldn't need that really. And we mainly use the PR530, and in the darker the skin type gets, or also the more tan people have, the more we are using VL555. Yeah, you see that here again, 400, very high absorption in melanin, PR530, less absorption, and 555, even less absorption. So this is actually the very important thing and the rule that we always have to follow if we don't want any side effects and any complications using Nordlers. I will show you a video here of a treatment, so you can see that it's a very fast treatment. We can differentiate in Nordlers between single pulse and double pulse. The double pulse is mainly used for pigmentation because so to reduce the thermal relaxation time. We adapt the energy always for sensitive areas. So be really careful on neck and décolletage. Always use at least 1 joule less than you would use on the face, and always make a patch, a trial shot first on the side of the face, and watch the reaction. So this is very important. Sometimes it can take even a couple of minutes until you see a proper reaction of the laser. So make sure you don't overtreat, and that you don't increase too much the energy. I find the settings, even the low settings that the Nautilus parameters are recommending us, are really useful, and you don't have to go so high here. Yeah. A crisscross technique is highly recommended so that we really cover the whole area, that we don't leave out areas that leave then dark stripes. Those are quite difficult to treat sometimes, and they don't look nice, so people are not happy with that. And always treat with those passes, so crisscross, one pass in one direction, the second pass in the other direction, and sometimes we consider a third pass, but not in all patients, so maybe only on resistant lesions if we don't see a proper response in them. Yeah, so wait for the reaction. This is, I find, really important. We are sometimes having strong reactions later on, even after a couple of minutes, especially when we are treating sensitive areas like décolletage or neck. So be rather conservative here. So I'm going to show you did you see already the video? I think so, no? So let's go to the next one. So what we are mainly treating, so you can imagine, oh, now you see the video, yeah. So you see we have a really big area to cover with one shot. So you can treat a full face usually in 3-4 minutes. It's really quick. There's no local anesthesia needed, and we have a cooling device that we usually apply afterwards. We also apply a nice mask, a calming mask later on, and then of course a sunscreen. But it's really a quick treatment to do and very, very tolerable for most patients. So what are we treating? It's mainly benign pigmented lesions, primarily solar and senile lentiginous on the face or on sun-exposed areas. We also use Nautilus a lot to improve skin texture and tone through rejuvenation. We do have a collagen rejuvenation as well here, and we see an overall enhancement of skin appearance. So you will notice that you do not only have an effect just on pigmentation, but really on the overall texture of the skin that patients do appreciate. We in our clinic tend to treat full faces and full areas always, and to avoid just treating a single spot. And people usually appreciate the improvement in the whole area here. We also use it when we address combined vascular and pigmented skin lesions, so like poikiloderma on the neck, on the décolletage. So that's also great. And we already heard about TRX, so the tranexamic acid. That's something that we use in darker skin type, but I'm sure you will hear about that later from the following speakers. So what is a very interesting combination, and I think this is where we are going now in the future, is combining different devices to even enhance the effects of our treatments, is the combination of SVT, so of the IPL, with non-ablative fractional lasers. So we have two different wavelengths here. One is 1550 and the other one is 1940. And 1550, as you know, it works in the deep dermis. So we achieve thermal coagulation there, and we use that a lot for skin remodeling. So in cases of scars and stretch marks, but also for improvement of the overall appearance of the skin. And the 1940 is a very interesting device here, which enhances the tone, texture, and glow. And also can be used for actinic sun damage. As you can imagine, in lighter skin types, especially on an island like where we live, people are too much in the sun and they suffer really a lot of those actinic keratosis, and we tend to use the 1940 to treat those actinic skin damage. As I said, this can be perfectly combined with SVT. So I'm going to show you a couple of cases. Here you can see a lady who had the PR 530 done, just a crisscross technique, and this is 24 hours later. So you clearly see the oxidation of the lentiginase on her cheeks. The skin is totally intact, but it has this discoloration, which usually takes about 5-6 days to disappear. We sometimes recommend patients to use a mild glycolic peel, maybe up to 10% to speed up this process a little bit, but they should not start using that before day 3 or 4. This is a patient who had a lot of actinic damage, so you might be able to see that on the left cheek. He had actinic keratosis, but besides that, also lots of lentiginase, lots of just a chronic actinic damaged skin. So we treated him with PR 530 with a double pass in crisscross technique, followed by followed by NFL 1940, so fractional non-ablative laser, the superficial one, with a high coverage, and then we applied the photosensitizer to the actinic keratosis and sent him into daylight for 2 hours, and he had a really great reaction on those actinic keratosis. So we used the 1940 as a drug delivery method for the PDT, and you can see here the results after just 1 session. And that's another lady. She's been in the sun all her life, as you can see, full of lentiginase, but also the skin looks quite dull. So we treated her with just 1 session with a combination of VL and PR, crisscross technique again. And you see not only the pigmentation has improved a lot, but also the glow of the skin has improved. So she looked so much younger, and the skin looked so much healthier after this treatment. Yeah, also décolletage, we tend to remind our patients to think about that area too and not to forget it. Most of the times, it hasn't been treated well, by many women, and looks so much more aged than usually the face does. So in this area, we also treat it with VL. So be careful here. Don't use the same settings as you would use in the face. Rather use VL, be less aggressive than a PR. With PR, you can really have heavy reactions here and leave them with discomfort for a long time and with a higher risk of pigmentation. Yeah, so this is the first session with VL. And then we did the second treatment with 1940 non-ablative fractional laser. And you see we cleared pigmentation, but also improved the skin texture of the skin. And they feel this lovely glow afterwards, and the skin feels so smooth. So women always enjoy those results very much. And that's another area which most people would love to treat. The hands, they show our age. And here you see a case. Can we see the video, please? With lots of lentiginase. Again, on the hands, be really careful and not so aggressive. I would rather recommend to use VL instead of PR. I had a couple of burns with PR. It was too aggressive, and when people were tanned before, so really be careful and rather use the VL. But again, as you could see, it's very easy to do. Crisscross technique. I always treat the whole hand, and it improves a lot the skin texture. All right, Notrix and sun, of course, this is an interesting question. Our patients, they have to use SPF 50. This is essential. I mean, as we know, UV is the biggest enemy of our skin, not only for skin cancer, but also for aging. So this is the most essential thing to do. But we also have to be cautious with pre-tanned patients. So we are now in a period of the year in September. Everybody is quite tanned from the summer, and we have to be really careful with the settings, so not to burn them. So, and we are rather better with VL than PR at the moment, and look always for the right reaction and don't overtreat them too aggressively. Yeah. So what's the big benefits for me for Nautilus? I must say for me it was a big game changer in my clinic. We use the device all day long. It has so many indications that it can be used for. It's a very safe device if you know how to use it well. It's rapid treatments. Yeah, so and the patient satisfaction is super high. We have great results, and of course, thinking about from profitability is also important once you have a private clinic. So I must say this is a device that really paid it off very quickly. Thank you so much.
Thank you very much, Cordula. That was very useful and very informative, with very nice before and after. So congratulations. Just before we move on, just one question, just to clarify, because you mentioned that in your slide, it says always 2 passes. So does that mean always 2 passes when you're treating pigments, or when treating Nautilus for vascular, you use 2 passes too? So perhaps maybe you can just elaborate how did you come to the conclusion that 2 passes would be better? Because most, when they start, will learn to use 1 pass. So maybe you can just elaborate on that, please.
It mainly refers to pigment. So with pigment, I must say we always treat in 2 passes with this crisscross technique to make sure that we have a good overlap. Yeah, you are absolutely right. In vascular conditions, you don't always need to use 2 passes. Even though I must say I do it almost as a standard now. But in pigmentation, I would really advise to do that, so to avoid this pattern that we don't want afterwards. Yeah.
Yeah, I agree, especially for pigmentation, and especially for the very light lentigos. When you have a very low contrast light lentigo, I find that with few shots or 2, sometimes even a 3rd pass just on the very light lesion, it helps better. So thank you very much. Thank you. So we'll move on now to the next speaker, who is a very dear colleague of mine, Professor Alina Arabiskaya, who is joining us and will talk to us about treating pigmentation with the Gentle Pro series. So that is the 755 and the 1064 long pulse. So Professor Arabiskaya, the floor is yours.
Thank you very much indeed. So my topic is treating pigmentation with Gentle Pro series. And first of all, I would like to say that I'm very grateful to Candela and to Dr. Firas to be the member of such a beautiful and such a useful seminar. So about the indication for Gentle Pro series, it goes away from the laser hair reduction, and benign pigmented lesions as well as vascular lesions, wrinkles, and even onychomycosis could be treated. Gentle Pro series is designed for treating pigmented lesions, helping to reduce their size effectively. And the mechanisms, it's important to discuss as far as pigmented lesions are a challenging field in cutaneous laser surgery. We are always afraid to heat the surrounding tissue in order not to create the post-inflammatory hyperpigmentation. So it is the focus heating which results in decomposing the melanin in the pigmented area and exerting it throughout the human metabolism. And what is very important, that the spectrum of lasers is huge, starting with ultraviolet, going to infrared. But in our interest now, 755 nanometers, which goes very well into the so-called melanin window, where light is captured more actively and the rate of absorption by other chromophores, for example, hemoglobin or water, is really much lower. And again, we are speaking about the concept of selective photothermolysis, and where chromophore itself and the cells it containing are heated and destroyed depending on the energy. But please look, there are some more mechanisms which are described concerning 1064. This is a nice experimental study on laboratory animals, and you can see here that collagen remodeling may happen as a result of a treatment with the high levels of type 1 collagen and so on. And this is interesting maybe in terms of our treatment of elderly persons. A spectrum of pigmented lesions is huge. In terms of the laser therapy, it's really better to subdivide them into epidermal ones, and the epidermal ones are of great interests for this particular topic, for athletes, lentiginous, pigmented seborrheic keratosis, café au lait macules, and so on. There are also epidermal, dermal, and dermal pigmented lesions, and the depth of the lesion may influence the selection of laser, but does not predict, unfortunately, the response to treatment. Here you can see a very nice result for treatment of lentiginous with alexandrite laser, and you can see here that with 10 millimeter spot size and a variety of parameters, it is 100% improvement. But what is very important for us, look, darker lentiginous achieved the greatest lesion clearance. This is very interesting and important for this technology especially. I would just like to remind all of us that lentiginous are not only limited to solar ones. Here you can see the classification of lentiginous, but even solar lentiginous has some types, for example, the ink spot lentigo, which is looking like reticulated black solar lentigo, which is surrounded by a classical one. And this is maybe also the aim for such type of the treatment. And in the case of periorificial and allocation of lentiginous and lentiginous in folds or generalized lentiginous, one should remind about the hereditary syndromes. So lentigo is just a very wide dermatological condition. The same about café au lait macules. You can see here a very nice paper, and here is the patient with café au lait macules, which were first analyzed, and then it was just a single treatment with 8 millimeters test site at 40 joule per square centimeter with a very good final result. The pigmented lesion, actually it is a benign tumor, seborrheic keratosis, and you can see here that it could be less or more pigmented. The pigmentation of seborrheic keratosis happens because of the activation of keratinocytes, which are proliferating, and also due to the activity of endothelin-1. This mechanism is involved in other pigmented disorders as well. There is a paper demonstrating the good effect of long pulsed 755 alexandrite laser. It was 1 to 3 sections with 6 millimeter spot size, 3 millisecond pulse, and using DCD cooling. And you can see here that it was there considerable improvement in all of the patients under study. And the second publication, you can see here the young patient with a multiple seborrheic keratosis, perhaps laser trilla disease should be excluded in this condition. And you can see here that there were 4 test spots with 100 joule per square centimeters and 8 millimeter spot size. And then 12 days after, some more treatments with a very good final result. There are some papers about Becker's nevi, but as the gentle marks 1064 was used for hair removal only. To whom and how? You know, to our own experience, mostly epidermal pigmented lesions are safe to treat. It is good working in light skin type and in marked pigmentation. This is very important. And also, we should remind that the activity of melanin production increases in elderly person. So the combination of pigmented lesions and atrophic skin changes with mild regimens may produce good results as well. So what are the steps? The first step is the diagnosis, and all of our speakers told today about it. The second is parameter selection. It is very important to perform the flash test, then the treatment. Normally, we use DCD switched off and post-treatment skincare, which is also essential. For the parameter selection, the rule is the shorter pulse, the higher fluence for light epidermal pigment, and for dark dermal, the longer pulse, the lower fluence. And also, I would like to stress again about the switching of the protective DCD, because we have a concept of preferential damage of the epidermal layer. And it is very interesting also to use different modes. A classical mode, just to work with a single lesion, but it's really not very interesting. And there are 2 safe regimens. One of them is toning regimen, and the second is painting. Which are performed by the distance from the skin, and the small spot size and high frequency and several passes is typical for toning regimen, and a large spot size and low frequency and 1 pass only for painting one. All of them are devoted to multiple lesions. And let me show you a very short video demonstrating the effect of a toning technique. You see here a very high frequency and also a small spot size. This is a toning regimen, and this is a painting regimen with large spot size and low frequency. Okay, let me show now some more papers. There are some publications demonstrating the use of 755 in combined pigmented lesions, but normally we tend to use another methods of pigment treating, but still I would like to demonstrate you these results. It is also very important to fix the darkening of the lesions from the patients of the skin types 1 to 3. It happens just immediately, and 15 minutes, something like this later, for the individuals with the skin type 4. And formation of a superficial red-brown scale is typical for 7 to 10 days. Here you can see just a mild regimen for treating solar lentigo and dyschromia. Here is the treatment with the big spot size, 3 milliseconds and 12 joule per square centimeters. It was just one treatment. Here is the lesion of a seborrheic keratosis, which needed 2 treatments, 10 millimeters spot size, 2 milliseconds, and 40 joules with DCD switched off. This is the treatment for solar lentiginous, also with DCD switched off. Here you can see the results of the result of 2 lentiginous, and practically the same patient also after 2 treatments. This is the lady with a post-inflammatory hyperpigmentation and 8 millimeters, 0.3 milliseconds, and 8 joules has been used in this patient. And also this patient with dyschromia, which was due to multiple chemical peels, light treatments, and others. And it was used 6 millimeters spot size, 0.5 milliseconds, and 16 joule per square centimeters with a high frequency. Here is the result of so-called painting technique because of the multiplicity of the lentiginous in this patient. You can see here the big spot size and 1 pass. And here is practically the same situation with a big spot size and painting technique in the patient with lentiginous on the back. So I would like to stress the versatility of Gentle Pro series and the safe use of toning and painting regimens. And also I would like to point out the combination with depigmenting agents and photoprotection is essential. And a special thanks to Candela Corporation for invitation, Medical Clinics Galaxy, Russian Candela teams, and Dr. Atmitbaeva and Gorokhova for enormous help. Thank you.
Thank you very much, Professor Arabskaya. That was fantastic. And I knew you would be the best person to talk about the long pulse alexandrite and pigmentation, because this is something that not many of us do.
Yes.
But it's a very helpful, very useful one. I'm sure there'll be some questions at the end, so stay around, please. And now
it's interesting because when you have something to hair removal, you can use it also for pigment. This is
absolutely
good.
Absolutely. Thank you for highlighting that. So now we're going to move over to the final speaker, and then we'll have the Q&A session afterwards, and that is Dr. Renita Rajan, who is joining us from India. I would imagine it's a bit late there, Dr. Renita. Dr. Renita runs a very successful clinic and has huge experience treating pigmentation in skin of color. So we're very excited to hear from you. Dr. Rajan, the floor is yours.
Thank you, Dr. Firas. I think you said it right when you spoke about how skin of color is having a moment right now, from being mostly handed down settings and parameters to actually developing them as required for Indian skin types and skin of color is very exciting. I think this journey with the Picoway system is there at the right moment, capturing the excitement of how laser systems can be worked for Indian skin type. So I just want to cover quickly some of the indications and protocols and use cases that I come across in everyday practice. So the challenges in treating higher skin types stem mainly from the high melanin load. This is fantastic for protecting against photocarcinogenesis, but the high melanin load also implies that every injury will be met with the pigmentation response. For example, we commonly see pigmentary demarcation lines, which are embryonic lines on the face which get pigmented after a period of, say, maybe about puberty and thereafter. And whatever pigmentation that naturally occurs, be it hair dye-induced pigmentation, be it mixed pigmentation, this tends to stay on for much longer because of certain patterns called acquired idiopathic pattern facial pigmentation. So now this is not so much a disease, but a natural occurrence. You see it almost in all of Asia, but you see it quite a bit in Far East as well as in Southeast Asia. So the thing about having pigmentary demarcation lines is that we may not see a uniform response when we treat with patients for laser toning or when we treat them for patchy pigmentation. And also there would be a faster rebound in these areas. It's very important. And these are also the areas that get re-stimulated to have more pigmentation because of the geolocation. I'm 10 degrees north of the equator, so it is very easy for pigmentation to come right back. Now, which means we cannot protocolize all treatments. We would love to have protocols. We start with the protocol, but then we customize them for individuals. In other words, we start with what's evidence-based for our skin type, and then we add the N=1 journey on that to see how this patient or this person can benefit from the treatment protocols. So the key factors here again are identify and differentiate between static and dynamic pigmentation. We have a lot of expectations around skin complexion where I practice. And you also have to take into account ongoing exposures, because it is not just UVB anymore. It is not just the SPF number anymore. It has to be the PA protection factor with UVA. But what we've recently learned is that visible light and infrared cause much more long-lasting pigmentation, LLP, long-lasting pigmentation, which can stay on for up to 9 months in skin of color. And in comparing UV-induced pigmentation versus visible light pigmentation, pigmentation induced by VL tended to be more persistent only in higher skin types. So in addition, we also have unique skin conditions like the hair dye-induced pigmentation. And one of the things that I feel compared to the skin type that was used commonly, or which we will be using at least for some more years now, would be to actually look at the melanin index and look at the colorimetry. Earlier, we did not have access to all of these tools, but now adding these, at least where we are starting to establish parameters for skin of color, is a game changer. Now, this is a small study I wanted to share about how you can have very patchy results. Initially, we used to think that right after the laser, you do have skin darkening or skin pigmentation. There's a pigment dispersal, and there you see a bit of darkening. And always we used to counsel patients that, you have this laser procedure done. After a while, things start getting better. But what interestingly, we noticed that even in the early days, even right 1 hour after laser, whatever areas that have actually shown an improvement in terms of increase in lightness index, the L value, and a decrease in melanin index are also the areas that are persistently showing responses after 1 week, and again, the same areas after 2 weeks. So initially I used to think like, yes, there is a disproportionate amount of pigmentation, especially when trying to assess response in people with hair dye-induced pigmentation. I'll share a few images after. I always wondered why some areas are responding better and some areas not so. I used to think that it's primarily the PDL, the pigmentary demarcation line, that's causing it. But what I've also realized is there would be a direct response to the existing pigment depth. And that's what we're trying to map to understand which patients will likely need more sessions, which patients will likely respond to some areas as compared to others, and then see how we can optimize Pico-Way treatments, Pico-Way laser system treatments. This is the long pulse Nd:YAG, the gentle YAG, comparing to the Pico-Way. And you can see that the Pico-Way system areas are consistently doing better. The next step is to quantify the exact amount of improvement and then use this as a way to identify which areas we should be focusing on. Now, therefore, to treat Indian skin types and skin of color, we understand that facial units are very important, and potentially the difference between the delta between pigmented skin versus normal skin could be a prognostic factor. Uneven results are possible. They are the norm, which means that you always counsel for more number of sessions when you do laser toning, because you're going to take time to respond. And we always look at customized protocols over common or standard protocols. We have a variable endpoint in skin of color and deeply pigmented skin types. And I usually see that an edema is a great endpoint that is adequate, but sometimes it's perfectly okay to not have any other endpoint as well. We find it very difficult to see erythema in our skin types. Very common to see acneiform eruption post-laser toning. You could see sometimes as a follicular reaction, but sometimes the response, the acneiform eruption stays well up to 3 to 4 days after. Good to combine exfoliants or retinoids in this case to enhance the outcome and reduce the acneiform eruption. Now, here are some facial unit-based pigmentations that we commonly see, the newer classifications where you can see more of the dark spots in certain areas of the face, photoaging predominantly affecting the forehead and the cheeks, and the post-inflammatory pigmentation. Now, this is from a Chinese study, quite different from where we practice. And this is also an idea to understand that patients are no longer looking at diseases per se, but also looking at improving conditions like photoaging overall, where they may not see specific problems, but as such want an improvement in skin tone in certain areas. Because of the higher pigment load in our skin types, and because lightening paradoxically causes more oxidation load on the cell, it's super important to be well balanced, especially when treating higher skin types with very high melanin. So if it is uncomplicated pigmentation, this is somebody with a post-inflammatory pigmentation, has tried multiple treatments, but not lasers, topical treatments, and has been with the pigmentation for close to a year. And this is a single session. The dermoscopy picture did not look as much like a post-inflammatory hyperpigmentation. We were concerned about potential ochronosis from bleaching serums, but she's cleared beautifully after just one session. This is a year's follow-up after. There was no endpoint. Now here is a complicated pigmentation. This is somebody, as I was speaking to you about the pigmentary demarcation lines here, you can see that there is a clear increase in pigmentation just around this zone, has had multiple chemical peels and lasers with complication of the pigmentation, deepening of the pigmentation. Biopsy showed a component of hydroquinone-induced complications like ochronosis as well. And then this has been what I would call as multiple doctors, multiple treatments. And she did pretty well with just very conservative settings, but given enough time and no endpoint. And here is another case of mixed pigmentation complicated by a topical application of hydroquinone. So we don't, in principle, use a lot of hydroquinone for preparation, primarily because of the risk of ochronosis, potentially because of the higher UV index. We recently published the largest case series of such complications of even with application of hydroquinone for even 2% for few weeks. And this is a very early onset and responded very well to the picosecond laser treatments. And of course, we use a lot of antioxidants to help enhance protection into the infrared and the UV and the visible light zone. And of course, topical tranexamic acid is a standard. It's almost like a SOP. And here are the settings, slightly higher settings as compared to the earlier one. And then 2 to 3 passes was trying for a bit of edema because the pigment density is quite high. 4 sessions, 4 to 6 weeks apart, and she's done quite well. Again, case of hair dye-induced pigmentation, very rare, maybe 10 years ago, but because everybody is using a lot more hair color and hair cosmetics these days, we see this a lot. Requires a biopsy, need to identify if there is a immunological component or if it is just pigment contact dermatitis, and then see how we can position the treatments thereon. The painting toning technique is very, very useful, but we must be aware that results will be patchy and look for areas which are low-hanging fruit and then see what is the delta between pigmented and normal skin and then decide how many sessions to prognosticate to the patient. Again, henna-induced pigmentation. Henna is very common in this part of the world, and people usually think that chemical dyes only typically cause skin pigmentation, but you can see that henna also causes pigmentation. This is henna from the plant, and that can also get, the lawsonin is used as a tanning agent, and that can cause facial melanosis as well. And you can see in these conditions where there is a lot of pigment and then there is a lot of dynamic changing pigmentation, it's very important to not go with harsh settings, but be very light. And more treatments for hair dye-induced pigmentation, very deep pigmentation, but doing very well in very sensitive skin as well. Again, multiple pathogenetic angles to this pigmentation with mixed pigmentation, complicated by addition of hydroquinone, doing pretty well. And you can see that this dense dark pigmentation is also possible to be treated, but be ready for a lot of edema in such conditions. Again, very good clearance, very good lightening, but this person is definitely going to be using more hair color after, and the challenge is to see how you can prevent it. Very refractory case, multiple treatments were tried, immunomodulators were tried. And in these conditions, I really trust the picowave laser system to not flare things up for me as compared to a nanosecond laser system. Sun protection should be definitely covering the entire spectrum, visible light as well as infrared. I prefer larger molecules, especially in patients who have had some level of photoallergic contact dermatitis. I prefer larger molecules which are very difficult to get absorbed. But of these, only bimetrozole and bisoprolol have UVA protection. And on actual sunscreen testing, they will show some protection in visible light and infrared also, especially if you can add a bit of antioxidants. Polysilicon is a great molecule, very, very large, but only has UVB protection, so not exactly useful for Indian skin type, which needs more of the UVA and visible light. Prefer zinc and titanium, least allergenic, but also can be irritant in higher doses. It's better to have a conservative lower dose, maybe anything around 30 to 50 SPF is still doable. Be aware of sunscreen's potential for triggering pigmentation, contact dermatitis, and in patients who are likely to have immunological issues. You should be wary of frontal fibrosing alopecia as well. And then if you look at lifestyle-induced pigmentation, here again, we can see that an area prone to repeat pigmentation but doing quite well. Nevoid conditions again do very well. And where I really love is the versatility of the Pico system is for using it in active acne, high fluence, smaller spot size, 1064 nanometers, and you see very good results, especially useful for higher skin types. In our case, higher skin types would be 3 and 4 compared to 5. See more of acne, which again makes it very versatile for post-acne erythema, post-acne pigmentation, and also good for textural changes. So take-home messages would be customized over regular standard protocols, very versatile, can cover the entire range of acne, post-acne pigmentation, post-acne erythema, and scars, in addition to treating complicated pigmentation. I had a total of 3 PIH cases, all of them in 2016 within a week of buying the system, but since then, touchwood, literally have had no flare-ups whatsoever, and this is my go-to in cases where I would be worried to use any other device. Combination, yes, possible. Laser toning, patchy results possible. Counsel and plan sessions accordingly. Spot treatments are always welcome to add a layer of additional clearance. Thank you. And await the questions.
Thank you very much, Dr. Anita. That was excellent. And as expected, high skin types with fantastic results.